Welcome everyone to our BJJ podcast for the month of May. I'm Andrew Duckworth and a warm welcome back to you all from your team here at the Bone and Joint Journal. As always, we'd like to thank you all for your continued comment and support, as well as a big gratitude to our many authors and colleagues who take part in the series that highlights just some of the great work published by our authors each month. So today for our podcast, I have the pleasure of being joined by three authors from two papers, one published in the February edition of the BJJ entitled Late Fracture-Related Infections in HIV-Positive Patients, and the other published in the May edition of the BJJ entitled Outcomes Following Lower Limb Long Bone Intramedullary Nail Fixation in South Africa. So firstly, I'm very pleased to be joined by Simon Graham, who's an academic orthopaedic trauma surgeon based in Oxford and Liverpool, along with strong links to Cape Town as well. Simon, it's great to have you with us.
No, thanks for inviting me and the team to talk about the paper today.
That's great, Simon. And secondly, joining Simon is one of Simon's colleagues in South Africa, Maritz Laubscher, who's a consultant orthopaedic trauma and limb recon surgeon in Cape Town. Maritz, it's great to have you with us as well.
Hi, thank you very much. It's an honor to be on the podcast. Thank you.
Thanks. And finally, joining Simon and Maritz is a senior author for both papers, Sithomobo Maqungo, who is a consultant orthopaedic trauma surgeon based in Cape Town. Sithomobo, it's great to have you with us. Thanks so much for taking the time to join us.
Hi, Andrew. Thank you for the opportunity to join the podcast.
So, Sithomobo, I think we kick off with yourself, and I was hoping you could maybe, as a background to the work you've done, maybe give us a brief overview of the current impact of orthopedic trauma in lower middle income countries, particularly in relation to the impact of lower limb long bone fractures and how these are currently being managed.
Thanks, Andrew. So basically, lower to middle income countries have a very high burden of traumatic injuries, and and then looking at our region in particular, Africa, we are the least motorized of the regions of the world, but we have the highest burden of of road traffic injuries. So who is typically affected by the traumatic injuries are young males, between the ages of about 16 to late 40s, maybe up to age 50. And those are, in many instances, on the continent, are the most economically active individuals. They are the breadwinners in their families.
Mm-hmm.
So any injury that affects them and that takes them off work, is a big burden for the family as well. And then also, for the healthcare systems as well, because, often in some of these regions, hospital systems are not well developed, and even treatment protocols within some of the hospitals are not well developed. So there's a huge disproportion of musculoskeletal injuries that are emanating from all the traumatic injuries that come through to the hospitals and tend to overwhelm the local trauma systems. And then there are also variations within certainly for the three countries we're looking at, Malawi, Tanzania, and South Africa. In that some of the, or rather, sorry, we're looking at South Africa only. But geographically within South Africa, there are, more rural parts of the country where, it takes a few days for a patient to get to the hospital. And so those ones tend to present with late injuries. And those that tend to live within the urban centers around Cape Town, which was the focus of the two papers, then they tend to have earlier access to healthcare and often, better outcomes in terms of infection. And then lastly, of course, there is a problem that is not uniquely South African, but definitely much more common in Cape Town, which is gunshot injuries. We have a high burden of civilian gunshot injuries that we see, and they also form part of this cohort.
Yeah, that's a really lovely overview you've given there. And actually, I think without going on to the results of your paper too soon, but I think that was one of the things that just struck me was the injury characteristics and the mechanism of injury in this patient population compared to what we see, for example, here in the UK. I mean, it's just completely different, and I think you've described it really nicely there, and particularly the motor vehicle accidents and the gunshot wounds, which we'll come on to. So, Maritz, maybe if I could come to yourself, that's sort of the lower limb trauma burden that, somebody really gives a nice overview of. Obviously, the other paper is related to HIV infection. What's the current burden for yourselves regarding this, and how is it impacting on sort of trauma and fracture care?
So HIV is a leading cause of morbidity and mortality around the world. And just a little bit similar to injury, this is disproportionately affect low and middle income countries with sort of 80% of the world's HIV positive population living in low and middle income countries. And the epicenter is sort of in Saharan Africa. And South Africa has the largest living population of HIV positive patients on antiretrovirals. Now, if you look in South Africa where we work, the population average HIV positivity rate around 10%, but trauma specifically affecting more younger males, that's sort of a higher risk-taking group. In our trauma population, up to 1/5, so up to 20% of patients are HIV positive. Now, HIV, just like diabetes, affect your immune system and could potentially lead to more complications like infection. So even though it's a large burden, historically, there's very low levels of evidence guiding our treatment. And there was a lot of anecdotal treatment of HIV positive patients in a different way, just based on perceived risk of infection. So we've done a lot of focus on showing that both healing rates after surgery for injury and as well infection rate is not that different and not enough, certainly to justify treating HIV positive patients different than any other patient.
That's really interesting, Maritz. And I think, like you say, that it's like it's really interesting about that burden in that lower sort of, particularly in the more deprived patients, that higher rate of HIV infection, and how you've got to deal with that, but also that linked with the more complex injury often as well, which I think is a really interesting thing that you highlight there. So Simon, maybe if I come to yourself, there's sort of two papers here, but based on one study. So there was a paper looking at the lower limb long bone nailing, and that aimed to evaluate the outcomes of lower limb nailing for long bone fractures in South Africa and look at predictors of outcomes. And then you've got the fracture-related infection paper that aimed to look at whether HIV infection is associated with FRI in patients that undergo nailing for their lower limb fractures. And these were both part of the host study. So maybe for our listeners, can you give us maybe some background about the host study and what it entailed?
Yeah, sure. So the host study stands for the HIV in orthopedic skeletal trauma study. So it was a group of studies that was funded by the Wellcome Trust, who are a big foundation based in the UK. And it came about, I was working not in South Africa, actually in Malawi as a junior registrar. And before I traveled to Malawi, I wanted to look at basically the cohort of patients I'd be seeing. And at the time, there was quite a lot of information in and around HIV. And as Maritz said, a lot of it was anecdotal. So there's quite a lot of evidence published by different people, including the Bone and Joint Journal, that said that people with HIV, this is sort of over 10 years ago, don't heal up their bones and essentially get non-unions and also have a high rate of infections. And it's all anecdotal, but obviously because we're orthopedic surgeons, all the anecdotal evidence actually gets printed in textbooks. So if you looked up in Miller in sort of 2015, it said that HIV is a risk factor for non-union. And if you went on Ortho Bullets, the same would be said. But I was in Malawi and I was basically managing patients with HIV and they all seemed to be doing okay. So I did some research out there on bone infection. And again, it didn't show too much difference between the HIV positive and negative patients. And I just thought, well, this is something that's unique. I was interested in research, so I applied to a big funder, luckily got some money, and that formed the basis of the host study. And the main focus of the host study was actually on non-union.
Okay.
And we produced a big study, published it in a HIV journal, actually. So a bit odd getting orthopedic surgeons publishing information in a HIV journal. But it basically showed that patients with HIV have no problem with bone healing. And it changed the textbook. So if you look up on Ortho Bullets, I've just done it actually, it's been removed. And Miller's, again, it's been removed as well. So it's actually, a relatively small piece of work, which has made a big impact. And through that funding, that's what formed the basis of these two patients. So the cohort of patients aren't identical, but the data collection processes were all funded through that stream.
That's fantastic, Simon. I think, like you say, just being able to debunk some myths that are out there is absolutely awesome. I think that's brilliant. And so for the host study itself, just maybe to give our authors, our listeners a bit of insight. What were sort of the inclusion and exclusion criteria for the studies, and what were the interventions?
Yes, we had to think quite long and hard about it because lots of the studies in the past have looked at lots and lots of different injuries, but we wanted to be very focused to see if we could actually answer the question more accurately. So we collected the information between September 2017 and December 2018 initially, and then it was extended for some of these studies. And we decided to only include patients who'd undergone intramedullary nailing of their femur and tibia, mostly because that was probably the best type, or the most accurate type of fracture we could determine union accurately using X-rays. Patients over the age of 18, so essentially adults. Exclusion wise, we excluded pathological fractures, obvious reasons around healing, intertrochanteric fractures of the femur, mostly due to issues assessing union of those fractures, brain injuries, burns, pre-surgical site infection, and any open fracture that basically presented over 24 hours, mostly due to issues of infection. And also patients who essentially we knew were never going to come back, which was actually quite a small number of patients. And that formed the sort of the inclusion and exclusion criteria. And then the intramedullary nailing study that we're talking about, the data collection period was just extended a little bit longer to March 2021.
That's really interesting, and I think actually, Sam, that gives you that good insight into what Sithomobo was saying before about actually that delay. So those patients who maybe had a delayed presentation, they're not part of the study cohort. Is that correct?
That's correct, yeah. Which is, it's difficult, isn't it, when you're trying to design any form of study? Ideally, you'd include them, but the likelihood is, they'd have a higher chance of developing infection. So therefore, it may influence your results. But we had to basically have some form of cutoff, and that was the decision we made at the time. But agree, it would have been ideal to include everyone, but it's not always possible in these types of studies.
Makes complete sense. So, maybe Maritz, if I could sort of come to you. Sorry, Sithomobo, come to you first. In terms of what data you collected, what was the baseline collected for the study and these papers in particular? You're on.
Sorry. Right. So, I mean, for the two papers, we went quite broad with our data collection. So we basically looked at, patient demographics. We looked at injury characteristics. Then in terms of outcomes, we looked at, surgery outcome and infection outcome specifically. So for the demographics, specifically, we look at the patient's sex, patient's age, and whether or not they use alcohol. We looked at smoking history and whether they use steroids, which of course are the things that may affect fracture union. And we looked at their HIV status, and this was whether they're HIV positive or HIV negative. And if they're HIV positive, were they diagnosed during this particular hospital stay, or did they know beforehand if they're HIV positive or not? And those were positive also whether they were on antiretroviral therapy or not. And importantly, we looked at the viral load, and we looked also at the CD4 count. Then we looked again at things like a patient's body mass index, and also because we were looking at a cohort from a low to middle income country, we also have an interest on just the social side of their history, and we sort of use the crowding index to determine where they fit in, and that looks at the number of people number of people per room in the household. Then we looked at the also functional scores like the EQ5 3DL, so we use that as well. And then we also looked at injury characteristics. Mechanism of injury. Was it a fall from a high standing height? Was it a fall from a height? High energy versus low energy? Was it a gunshot injury? And if it was assault, was it assault with a blunt object or assault with a sharp object? I spoke about it earlier, low velocity gunshot injuries. And if it was a motor vehicle crash, was it a pedestrian, passenger, or a driver? And we know that I did allude to it earlier on that Africa has is the least motorized region in the world. So the few cars that are available, tend to transport a large number of people. So there are lots of passengers, far more than drivers. And also, I suppose, as a function of a low to middle income country, we have a lot of pedestrians that walk on the highways, and they also get knocked down by cars. So that's where the high proportion of tibia and femur injuries come from. And then we looked at other injuries sustained by the patient, and if they have also other orthopedic injuries, and then looking at the injury severity score, if it was lower than 16 or above 16. Then we look at the open fracture characteristics, how it was managed. Was it washed out, and plaster cast applied? Was it wash and an X-fix, or wash and intramedullary nail? Then we look at the antibiotics, whether they were administered pre-operatively or only afterwards. And then lastly, we look at the surgical outcomes in terms of union, non-union, and malunion. And then also for infection outcomes, we collected data on whether it was early or late fracture-related infection, and whether it was superficial or deep infection. So as you can see, we were quite comprehensive with our data collection, and yeah.
100%. I mean, the baseline data, particularly like everything that's collected there, is incredible. And you've touched briefly on the outcomes, but maybe Maritz, if I come to you, just a bit more about the details of the outcomes that you guys collected and how they were sort of defined.
So, if we look at the outcomes of the lower limb long bone intramedullary nail fixation study, we mainly looked at union rates and rates of infection. And when it comes to union, we looked at delayed union as defined as not united in 6 months for a lower limb long bone fracture, and non-union as not united in 9 months. Then we also looked at infection rate, and infection was separated into early surgical site infection, which was before 90 days, and late infection after 90 days, basically using the CDC definitions, which was probably, at the time of the study collection, was the sort of standard definitions for these. So basically, in the outcomes study, we found delayed union rates of around 18%, and non-union rates of just under 6%, and an overall infection rate close and open fractures combined early and late at around 6%, which showed that in this population that was equivalent to sort of study populations published from high income settings. Specifically looking at HIV, we compared the early, late, and overall infection rates in the HIV positive and the HIV negative group. Of all the patients, I said just around 20% were HIV positive, and there was no significant difference in the early infections between the two groups. But interesting, and contrary to sort of most recent literature, there was an increase in the late infection rate in the HIV study population, which sort of makes sense because, HIV is a disease that affects your immune system, just like diabetes. The degree to which it affects your immune suppression depends on how well it's controlled. So in other words, poorly controlled or poorly suppressed HIV, just like poorly controlled diabetes, will have a greater effect. So that will lead you to think that, it might differ over time if patients' compliance to treatment changes. It was quite an interesting and a little bit unexpected finding that it showed an increased late infection rate in the HIV positive population.
Thanks, Maritz. And I think that leads us in nicely to those sort of results and give those sort of headline overviews. So, I mean, if I could sort of maybe come back to you, because obviously those are the sort of headline findings that, Maritz has just highlighted. Is there any other particular findings in the results that you'd want to highlight, and any of the thing, particularly the analysis you performed, because you did some regression analysis, didn't you, as well?
Yeah, I mean, everyone loves not really knowing what regression analysis is, don't they? But essentially, we use univariate and multivariate regression analysis. So univariate analysis, essentially, you take an outcome which we, took as infection, and then you compare it with a predictor, which, could be HIV, and just compare, see if HIV is a risk factor for basically developing union. The problem is that doesn't take into account lots and lots of other different confounding factors. So that's when you bring in multivariate analysis, where you basically add in all the confounders and see if that predictor still impacts the outcome, and the outcome being for the HIV paper infection. So that's what we did. The problem with regression analysis, you can only include a certain number of confounders before the whole thing explodes. So you can only include sort of 6 or 7. So that's the problem with it.
Yeah.
One of the things in the analysis is probably important to notice when you go through, particularly not the HIV paper, but the outcome IM-nail paper, is that some of the numbers, the number of missing data is reported in the paper, but some of the figures don't add up, essentially because some of the patients just didn't have the data for. So when you're reading it, the reason why some of the figures are up and down is because there was some missing data, because these are an extremely difficult patient group to follow up. And we could maybe talk about the follow up rate next, potentially.
Yeah, then that's exactly right. And I was hoping like you just sort of talk about how you did follow them up, and then what was the data collection like? Because obviously you collected outcome scores as well, did you, in terms of PROMs as well?
Yeah, so the data collection was hinged on people. So we basically had to employ really good people, and we had 2 really good nurses, Nasipa and Nomsa, and they went above and beyond to actually follow these patients up. Following patients up in a challenging environment is not easy. And it's very different to the UK, where in all the trials we do in the UK, we get someone in office to send them a message, and they fill in a text message and give them a PROM, and that's it. The nurses phone the patients several times a week, several times over the weeks. We paid them for their time. It was only a small payment, but we did reimburse their time. But in patients who essentially couldn't find, on some occasions, the nurses got into taxis and went to the region where patients were essentially homeless, and physically found them on the street and brought them in a taxi to the outpatient appointment. So that's sort of the length that the nurses went to basically, to follow up these patients. And because of the hard work of the individuals that still work with us, there's some of them are still research with nurses working in Cape Town now. The loss to follow-up rate, even after a year, was less than 10%. So it's pretty amazing, really.
Incredible.
Certainly wouldn't get that in the UK.
No, and that's amazing. And in terms of, just to highlight from the Longbone paper, that finding of the overall health-related quality of life was comparable between the open and closed fractures. I found that at the 9-month follow-up anyway. That was. What was your sort of interpretation of that? I found that quite interesting, because obviously the nature of these open injuries is quite different than what we see here in the UK as well.
Yeah, so it is interesting. So it could mean that basically they're all sort of okay, or it could mean the tool that we're using isn't working, or it could be a bit of both. One of the challenges when you're filling out the forms is that, if you ask if someone's okay, which essentially is what the EQ5D is, the majority of people say they're okay. So it could be the fact that these patients are recovering well. It could be the fact that the tool doesn't work quite as good in this setting, or it could be a combination of both. But also, if people don't recover, and if people don't go to work, the health system around them isn't as supportive as it is in the UK. So essentially, they're not getting paid. They can't feed their family. They can't feed themselves. So there's good motivation to essentially get better. And maybe Maritz and Sithomobo could comment on that, but that could potentially be something which basically means that, to a degree, maybe patients do a little bit better because there's slightly more motivation to recover. I don't know.
Yeah, that's very interesting, isn't it, Simon? And that sort of takes me back to you, Sithomobo. Maybe if I could ask you, sort of drawing all that data together from the 2 papers, what do you feel the key take-home clinical messages of the studies are, and the real strengths of it, which are clear to me?
Yeah. So look, I think, firstly, it's important that these papers highlight the fact that high quality and high impact research can be performed in a low to middle income country. And I mean, this is like these are part of the largest studies that have been performed that look at clinical outcomes and look at PROMs, in patients with long bone fractures, and that despite the challenges faced by low to middle income countries, the results are actually comparable to what's achievable in a higher income setting. And then secondly, we've also, provided new information and also, added onto the existing body of knowledge for some of the known science.
Mm.
We've shown that, HIV, is a risk factor for late, fracture-related infection. But we've also shown once again that, whether you have HIV or not doesn't affect your rate of early, fracture-related infection. And also that, if you look at, gunshot injuries versus open fractures from blunt trauma, that gunshot injuries have a lower infection rate compared to blunt trauma.
Mm.
And yeah, so I think probably the for us, like the main highlight is that we've shown that HIV, despite I think Maritz did allude to it earlier on, that despite previously published data, but the presence of HIV is a risk factor for late fracture-related infection.
Yeah, and that's very good, Tamara. And that leads me to you, Maritz, in terms of how do you overall feel this data does fit with the current literature? And I suppose, importantly, how do you feel it fits with your practice? Is this what you sort of expected to see?
Yeah, so I think, as I said, the results was a little bit unexpected, and again, sort of other recent published literature, but I mean, it does make sense if you think about it. I think it confirms with no a difference in the early infection rate that there's definitely not enough evidence to treat someone that's HIV positive different in the acute setting. So, you can treat the fracture on its merit. It is something to be aware of. Then if you follow patients up, that they might be more prone to late infections and maybe help you to have to always keep it in mind if you see the patients in the future and treat accordingly. So I don't think it's sort of strong enough evidence to change practice. But it just sort of helps informs our current practice, which we have as to in the acute setting. Certainly, it is something that we use to risk stratify a patient, but we don't treat any differently than another patient.
Yeah, I totally agree, Maritz. And I think that's the thing, isn't it? You can just you can carry on and treating it as you would do normally, but just with that in the back of your mind. I think that's exactly how I interpreted it. And so, Simon, if I can maybe sort of come to yourself now, and maybe sort of two questions just sort of to finish up. What do as you said, you designed this quite some time ago now. Do you any sort of limitations to it, or anything you would want to change now? And then what does the sort of future hold? Because this is such an amazing achievement, I think, in terms of what's been produced, and I think it gives us such valuable data that we just often don't get. I think it's just such an amazing achievement because it's a very different patient population, very different mechanism of injury, and all these things compared to what we see in sort of the higher income countries.
Yes, so I think I think it's a good question. I think that from the two papers, we've already spoke about what they show, but I think it's important to think about where the setting. South Africa has amazing surgeons, amazing resources. But when you think about, there was nearly 600 patients in the intramedullary nailing paper. Half of them were done outside of working hours.
Yeah,
A lot of them were done at night time.
yeah,
And almost every single one of them was done by a resident, or as we'd say, a registrar in the UK. And what the paper shows that the burden of injury is very high. A lot of these injuries are managed out of hours by trainees, but actually, when you look at the outcomes of the closed injuries,
mm,
you look at the outcome of the open injuries, even in that setting, the outcomes are basically the same as a high income country. So that's something that's really positive because it sort of gives a benchmark for other countries and other institutes to show how well these injuries can be managed in that setting. And maybe it gives us something to think about in the UK, that if the results are so similar, how are we managing them in our country?
Yeah, absolutely.
And with the HIV paper, I think it is probably important to highlight, because we are going to come across and manage patients with HIV in a trauma population, is that if you look into the results, the late infection rate was higher, but actually a lot of those patients weren't on antiretrovirals. So if you look at late infection in particular, if you're on antiretrovirals, it looks like your infection rate was probably actually similar to HIV negative patients. If you look at the cohort overall, so basically your risk of developing any infection, be that early or late, HIV still showed an increased rate of infection, and antiretroviral therapy wasn't actually protective for overall infection. But certainly for late, if you're on antiretroviral therapy, you were probably okay. Whereas if you weren't, your risk of getting an infection, you're not definitely going to get an infection, but it's just higher. So I think for overall for patients, because essentially patients may listen to this, patients may read the paper. If you and also surgeons managing these injuries are going to read the paper. If you are a patient with HIV, or you're a surgeon managing patient with HIV, you test their viral load, which shows how well the virus is being controlled. You test the CD4 count to see how their immune response is. If they're not on therapy, start them on therapy. If they are on therapy, just continue with therapy. And then just treat them in a similar way to HIV negative patients, and just be aware of the risks moving forward. I think that's probably sort of an overall summary of the two papers. And then moving forward, as a group, we're doing lots and lots of work in and around trauma. So we've got a large amount of funding from NIHR to establish a global injury group, which is an NIHR global health group. So the first global health group in orthopedic trauma, which Maritz and Sithomobo are the lead investigators for. And that's looking at trauma across Tanzania, Malawi, and South Africa, focusing on the burden of injury, healthcare resources, how patients are managed, their outcomes, and looking at introducing feasibility trials. So we think about sort of the way forward with regards to trauma itself. Over the coming years, it's very exciting with the establishment of the Global Injury Group. So anyone can get in touch with us about that. You can contact me, Sithomobo, or Maritz. And with regards to HIV, there's been a lot of work in and around union. I think union question has probably been answered. There's lots of work around elective surgery, particularly on hip replacements. And I think, again, you can manage HIV positive patients the same as HIV negative. With regards to infection, there probably is an unanswered question there. The problem with to answer it, you're going to need a lot of patients.
I totally agree.
And you're going to need a lot of money.
Yeah, absolutely. Well, Joe, so that's a really nice place to wrap it up. But congratulations to all three of you and the whole team. I mean, what an amazing collaboration! Actually, the way that you're moving it forward as well with the NHR Global Injury Group, and I think that's just such a positive thing. And I think there's so much we can learn from that, and actually so much positivity that can come out of it. And congratulations on two great studies that were published in the journal. And it was so nice to have you all with us. And to our listeners, we do hope you've enjoyed joining us. We encourage you to share your thoughts and comments alike through our social media platforms. Feel free to post about anything we've discussed here today. And thanks again for joining us, everyone. Take care.